Hi, everybody, once again. This is part two of the one I started today, April 21st. The recording cut out kind of abruptly at about 12 minutes. I didn't notice it. So I'm continuing on then, and I checked back, and we started at respiratory. So I was just getting to the basically full focus onto the respiratory diseases and really the underlying factor, and maybe just reiterating the same point is that you can find every kind of organism in the mouth and therefore in the throat. So there'd be nothing out of the ordinary just based on what we consume in our environment and who we interact with. All of those things, whether it's staph, whether it's strep, whether it's diphtheroids, whether it's yeasts, whether it's anaerobes or aerobes, gram negatives or gram positives, rods or cocci, doesn't matter. The consistently important one that causes still a vast majority of problems for strep throat, group A, beta hemolytic, Streptococcus pyogenes. That's the player that's there. The group A is that carbohydrate marker that is the focus of being able to do rapid identification. It's more reliable for the pathogenicity, in other words, how nasty it is, of the strep throat, better than beta hemolysis as a predictor, and that's an important part of why you should stay Group A with regard to that. And the biggest problem associated with streptococcal diseases is the fact that they just do a number on your immune system. Your throat will be fine, but the immunological products and the immunological response that it induces are severe. Uh, whether it's scarlet fever with the erythrogenic toxin or whether it's toxic shock syndrome, all of those are complications that are based on either super exciting your immune system, glomerulonephritis, where massive antigen antibody complexes form that can't be filtered out effectively and damage the kidney, whether that's an impetigo or whether that's from strep throat. And again, undertreated or inadequately treated or untreated strep throats are where these present a lot of the problems. Again, all of these are immunological in nature, and perhaps the most noteworthy one is rheumatic fever, where effectively the antibodies in the immune system's antibodies are attacking normal structures, particularly the lining of joints and the lining of heart valves. Rheumatic indicates joints, and the fever associated with it is certainly inflammatory, but it was certainly the most common cause of damage to heart valves for the longest time, and perhaps still plays a significant role over the course of time. And then that leads to things like bacterial endocarditis, which is something that's really not part of the exam, but just to show you, give you an idea of how severe it is. So I think the immune system plays a significant role with regard to that. We talked about diphtheria. And diphtheria, that shocking anecdote that I always tell about that's absolutely true with regard to this is where it's all about the toxin. The toxin creates that pseudomembrane, that sort of false gray-white lining area in your throat that can peel off and cause people to choke and they can't breathe. But in the meantime, that toxin gets into the bloodstream. It can damage the heart, the nervous system, the kidneys. And again, even with treatment in the unvaccinated, now you're looking at a very, very significant death rate. That's part of it. Another significant point is those three, remember, it's about one third to two thirds viral to bacterial. So bacterial infections predominate, particularly when it comes to conjunctivitis, sinus, bacterial sinusitis, and otitis media. And they are typically those two that you have to remember. This isn't strep pyogenes, this is streptococcus pneumonia and Haemophilus influenza, which are both relatively normal bindings in of respiratory bacteria that we commonly find normally that are there. And that's why we use amoxicillin if people are not penicillin allergic. Certainly, you adjust that if there's any special considerations like augmentin or penicillin allergies and things like that. But those are the two big players. And we always, and inevitably, once that diagnosis is made for any of those, you're going to use antibiotics, and particularly for otitis media, you're going to do that consistently. And if it just doesn't resolve, then you have to provide ventilation tubes So that's that, basically putting tubes in someone's ears, a fancy name called myringotomy. And it's a very, very easy, quick procedure that's very effective. And the criteria may have changed today uh, with how many infections over a given period of time. I know back when my kids were little, it was, 7 to 9 infections over the course of a year. Then they strongly considered. My daughter had 2 sets, I told you. Coffee break for voice, since I'm doing this a second time. Rhinoviruses for the common cold, even though we'll see adenoviruses for the more severe cold. With adeno meaning swollen glands, sore throat, maybe a fever. We all are familiar with what cold symptoms are. Coronaviruses, up until they reared their ugly head with the novel viruses of the COVID era, were really a source of the common cold. Bacterial pneumonia, again, it's a relative. What's interesting about that is the vast majority of community-acquired cases are, again, normal flora for most of us. A normal microbe called Streptococcus pneumonia or Diplococcus pneumonia or pneumococcus are all the same thing. That's the most common cause. You all should be familiar with these. We look at the blood-tinged sputum, the coughing, the fever, the chest pain, all that difficulty breathing, all of those things. There's so many different signs, and frequently they can come with a relatively sudden onset. And we look at to see whether this, gives you a clue. Is it rusty colored? And that's partially hemolytic. Is it all red? And maybe you're looking at Klebsiella pneumonia. The common denominator with a lot of these is the capsule, because what happens is it resists phagocytosis, which is our principal defense, and with this massive amount of macrophages constantly scrubbing the respiratory system. What happens is now that creates a significant problem if that primary defense is inadequate. So the capsule is a consistent anatomical feature. The oddball is walking pneumonia. Walking pneumonia is just that. It's a pneumonia that isn't as severe. You don't have that 103, 104 fever. You can function. And so again, we see it in dormitories, we see it in barracks. That's why it was called walking pneumonia. It doesn't have a real cell wall. It's mycoplasma pneumonia. You can't use cell wall antibiotics, but it has a relatively long onset and a relatively long course and a relatively long recovery. It's that time, but thankfully it does respond to antibiotics, over time. And as long as, typically you're looking at fibromycin or the Z-Pak being able to treat that. And that's part of it. Whooping cough, went through the whole story with that. You can go back and listen to those things. Called pertussis, that whoop sound that's there when we see it in older children or in toddlers or older adults. Then we can be more chronic in nature. As opposed to that one that we really is scary, and why the immunization is there for infants and again, just like diphtheria, without those immunizations, there's a very significant death rate. And that's really the tragedy of all of those types of things that are there. You can recall the anecdote that I told about Legionnaire's disease. And it's really, the problem is that it's very much like influenza. And that's why the original error was made in thinking that this was some type of unusual recurrence of that terrible, horrific flu of 1918, 1919. But the reality is this is something that people who are at risk uh, have a much larger, much more likely uh, chance of exposure and getting sick from, comparatively, because the bacteria is there. It just has to be a confluence of factors. Those older ventilation systems, or near any type of water where we can get dust and water together with warmth, is a bad combination. And I mean, that was the original one that with the deadly results was the large number was in a lot of older veterans. We're talking World War I and World War II vets back 50 years ago. We had in the bicentennial where it got its name. And the other outbreaks have been in a vets hospital here in Pittsburgh, and in overcrowded conditions with people in a poor socioeconomic strata. People who are at risk and overcrowded in New York City. That was my recollection of 3 that got a fair amount of publicity that were there. So that's the problem with that. Again, and you have to understand it was flu-like symptoms. What makes influenza influenza is the fact that it affects it affects everything. It's not like a cold. It's not just like a chest cold. I mean, you're sick. You have a chronic fever. You're very weak. You're nauseous. You have all sorts of gastrointestinal symptoms and dizziness, profound headaches. I mean, you're down and out. I mean, it's a good week where you're just not doing anything, and maybe a week to 10 days more minimum on top of that to finally start to feel like you're getting better. So those are very severe when you talk about influenza, and that's the relationship between the antigenic shift and the antigenic drift. This one's the cause of the drift. Those subtle changes in the H and N markers that are because it's a virus that mutates consistently. That's why there's a relatively lack of reliability for influenza vaccines, even though they're recommended for everybody at present by the CDC. It wasn't that way. It used to be the very old and the very young, people in healthcare, and people at risk. Now the recommendation is still for everybody to get a flu shot. I mean, and then the intersection of politics and medicine is not a good one. But the reality is that it's a trivalent vaccine. There's three different strains that they're trying to, from epidemiological evidence, make maybe 3 to 6 months minimum before the next flu season comes around. And the nature of those mutations, albeit subtle, render those less likely to succeed. And again, and the risk of getting immunizations is always present. You're doing something invasive, and there's a variety of different syndromes. The one that comes to mind has got a fancy name that you don't have to know about, called Guillain-Barré syndrome, which is a kind of paralysis that can come from a variety of things, not the least of which are immunizations. Because again, it's something from your immune system it's very, very difficult to predict. So with my current feeling, well, I don't get them anymore. It's the percentage of them being successful doesn't outweigh the need and the chance of getting some kind of complication. Most of us sitting here, myself and you, are relatively healthy individuals, are unlikely to succumb, means die, from the flu. So if you're likely to survive it without major problems, do you really need the immunizations? It's more of convenience, I think. But all that aside, there's people who need to get it and should get it based on what's going on. I mean, again, your workplace may have different concerns with regard to those things. Let's see what I'm looking at here. So I think you know that. Okay. I lost my train of thought there, and I know we did whooping cough, and here we are with Legionnaires. Oh, in the skin, what I forgot to mention is so important: is Lyme disease. Again, it's a spirochete. It's based on your immune system, the target-shaped rash. The typical time we experience Lyme disease, which is now, and for the next maybe 5 months or so. It's when, well, maybe not now because it's a little bit colder than typical, but it's usually at the start of spring, maybe mid-spring, all the way to mid to late fall. Once you get a couple of good hard frosts, remember, it's all about the life cycle of the tick. Right now, when the weather starts to get warmer, the ticks go from wherever they have been resting, okay, and the eggs hatch. And at that point in time, because they fall off the deer, the eggs hatch. Now those tiny little guys, which are already infected, are looking for blood meals. They're hungry, and whether it's a dog, whether it's another field animal, whether it's us, they jump on and latch on, and then that's where Lyme disease comes from. Remember, Borrelia burgdorferi, it's a gram-negative spirochete. You have a lot of immunological problems associated with it. That's really the significance. It needs to be treated early on. If not, the treatment is antibiotics, which are readily available. But if it isn't treated early enough, there are significant problems with regard to it. So I think that's part of the problem as well. Hmm. Okie dokie. Hold on. I'm just trying to look at 16 messages, which I will. Give me 1 second. Okay. Let's see. I'm looking at. Okay, I was doing the Lyme disease nugget, and it's just hard to do when we're trying to do this. You have to look at messages. Can't keep things out of the way. So again, the influenza, a variety of symptoms that are there. The Lyme disease, very significant in the immunological things that it plays on. Okay, and again, that antigenic, the distinction, and that's really where I was, is the distinction between antigenic drift, which happens all the time and impacts the vaccines. And again, it's trivalent. We're looking for three. They're influenza A. And it makes it difficult, where antigenic shift is when we get these novel viruses. And really a similar process what happened with COVID is, however it became COVID, was that now you have multiple players, like a farm with birds, with ducks, with chickens, with pigs, and horses. And all of a sudden you can get this worrisome combination where an unexpected virus comes together that our bodies have never experienced, and it's a very vicious reaction. That's antigenic shift, and that's the scary thing. So that's an important thing. Again, the vaccination is right now recommended for everybody. I have to be wary of that. RSV is becoming a bigger player than it used to be, considerably so. And so RSV, again, typically in younger children. So we see now the problem is in the young and the old. You're being tested for it more frequently. The big player is that probably see more of it in toddlers and kids, as presenting something called the croup. That's there. So I will stop there for now, and I will continue on and pick up with tuberculosis where I left off, and continue doing this presentation for you. Thank you once again. Bye-bye.